Hi and welcome to this audiobook on community-acquired lower respiratory tract infections. Let's begin by discussing adult community-acquired pneumonia epidemiology. It is pneumonia with onset outside of the hospital setting or less than 48 hours from hospital admission. It is the leading infectious cause of hospitalization and death. It disproportionately affects the elderly. That is, 2/3 of affected patients are above the age of 50 years. Mortality ranges from less than 1% to 50% depending on severity of illness. It costs billions of dollars in healthcare costs annually. Community-acquired pneumonia, abbreviated as CAP epidemiology take-home points. It is very common, and very deadly. Let's now discuss adult community-acquired pneumonia etiology. Its etiology has evolved over the years, with Streptococcus pneumoniae becoming less prevalent with routine vaccination in the US and studies showing viruses are a common CAP cause. Streptococcus pneumoniae is still the most common, followed by Haemophilus influenza and Staphylococcus aureus. Atypical pathogens like Mycoplasma and Chlamydophila are less common among inpatients because these generally cause a less severe form of CAP, also known as walking pneumonia. Legionella species can cause a more severe form relative to other atypical organisms and thus is more common among inpatients. Gram-negative organisms other than Haemophilus influenza are uncommon, but Pseudomonas aeruginosa and Enterobacteriaceae are sometimes isolated, particularly in patients with recent healthcare or antibiotic exposure. Although viruses are common, there is no currently available diagnostic test that can reliably differentiate viral from bacteria pneumonia or detect viral bacterial co-infection. Even in studies where etiology is aggressively pursued, an etiology is never identified in the majority of patients, resulting in the use of empiric antibiotic therapy for the duration of treatment. Pause the video and scrutinize the table summarizing adult community-acquired pneumonia etiology. Let's now consider diagnosis. It is based on symptomology and radiographic findings. That is, clinical features and demonstrable infiltrate on chest radiograph or other imaging technique, with or without microbiologic information, including cough, fever, sputum production, pleuritic chest pain. Diagnosis is based on both symptomatology, and radiographic evidence is more sensitive and specific relative to physical exam alone. Diagnostic tests for etiology are based on disease severity and risk for certain pathogens. Refer to Table 2. Routine diagnostic testing is not recommended in the outpatient setting. Testing among inpatients is based on CAP severity, as shown in Table 3, risk for methicillin-resistant Staphylococcus aureus, abbreviated as MRSA, Pseudomonas aeruginosa, or Legionella pneumophila. Lack of outcomes data indicating tests for etiology improve outcome, but testing is important to ensure optimal therapy when mortality risk is high, broaden and/or narrow therapy when there is multi-drug resistant organism risk, and provide Legionella surveillance when it is suspected. The major change in 2019 guidelines is recommendation for sputum and blood cultures in all patients at risk for or empirically covered for MRSA or Pseudomonas aeruginosa to improve appropriate use of anti-MRSA and anti-pseudomonal therapies. If testing for Legionella via urinary antigen test, it is important to also send sputum for selective media culture or nucleic acid amplification. Empiric antibiotics should be initiated in patients with suspected CAP regardless of initial serum procalcitonin, abbreviated as PCT concentration. It has a sensitivity of 38 to 91% for community-acquired bacterial pneumonia, abbreviated as CABP. The optimal PCT diagnostic cutoff is unknown, i.e. 0.1 versus 0.25 versus 0.5 nanograms per milliliter. PCT concentrations in CABP caused by atypical bacteria is similar to viral CAP. Sensitivity for CABP caused by typical bacteria is better but still suboptimal 87.6%, with a 95% confidence interval of 81.1 to 92.1%. Pause the video and scrutinize the table summarizing diagnostic testing for CAP etiology. Pause the video and scrutinize the table summarizing severe CAP definition. Let's now look at site of care decisions for adult patients. The decision on whether patient requires hospital admission should be based on CAP severity assessment. The Pneumonia Severity Index, abbreviated as PSI, or Pneumonia Outcomes Research Team, abbreviated as PORT score, are now preferred over CURB-65, see Table 4. It better identifies patients at low mortality risk. Data suggest it increases the proportion of patients treated in outpatient setting without resulting in adverse outcomes. The lowest risk patients can be assigned to risk class 1 without extensive diagnostic laboratory workup. They include those with an age less than 50 and in the absence of neoplastic disease, heart failure, cerebrovascular disease, renal disease, or liver disease, and with normal mentation, pulse of equal to or less than 125 beats per minute, respiratory rate of equal to or less than 30 breaths per minute, systolic blood pressure of equal to or more than 90 mm of mercury, with a temperature of 35 to 39.9 degrees Celsius. Patients not falling into risk class 1 require more extensive laboratory and diagnostic evaluation. The CURB-65 score is still conditionally recommended as a method to determine the need for hospital admission, see Table 5. It is based almost entirely on readily obtainable physical examination and patient data. The only laboratory parameter required is blood urea nitrogen, abbreviated as BUN. In the absence of BUN, there is some use of the scoring system abbreviated as CRB-65 score. Severe CAP criteria, shown in Table 3, are now recommended over both PSI and CURB-65 to determine need for levels of care higher than general inpatient ward, that is, ICU, step-down unit, telemetry. Although PSI and CURB-65 predict mortality well, severe CAP criteria and scores using similar criteria better predict need for ICU admission, vasopresses, or ventilation. Patients requiring vasopresses or mechanical ventilation, which are both major severe CAP criteria, warrant immediate ICU admission. In absence of major severe CAP criteria, minor criteria should be used along with clinical judgment in determining need for higher level of care. No specific cutoff has been endorsed, but data suggest one major criterion or three minor criteria are 84% sensitive for ICU admission. Pause the video and scrutinize the table summarizing Pneumonia Severity Index (PSI) or Pneumonia Outcomes Research Team (PORT) score. Pause the video and scrutinize the table summarizing CURB-65 score for quantifying CAP severity. Let's now look at empiric therapy, with an emphasis on adult outpatients. Treatment recommendations are based on the risk of macrolide-resistant Streptococcus pneumoniae, including comorbidity, local susceptibility, and previous antibiotic exposure. The major change in 2019 guidelines includes the fact that amoxicillin and doxycycline are now preferred to macrolide in patients without comorbidities. In patients with recent exposure to one of the above antibiotic classes, use an antibiotic from a different class. Consider MRSA or Pseudomonas aeruginosa coverage in those with risk factors, that is, MRSA or Pseudomonas aeruginosa respiratory culture in the past year, hospitalization plus IV antibiotics past 90 days. Pause the video and scrutinize the table summarizing empiric therapy, with an emphasis on adult outpatients. Let's now look at empiric therapy, with an emphasis on adult inpatients with non-severe CAP. There is no preference between beta-lactam plus azithromycin or an antipneumococcal fluoroquinolone. Only substitute doxycycline for a macrolide when there is macrolides are contraindicated, e.g., in the case of QTC, interval prolongation, etc. The major change in 2019 guidelines is that there is no more healthcare-associated pneumonia HCAP, and there are very specific indications for when to provide MRSA and/or Pseudomonas aeruginosa coverage. See Table 7. Pause the video and scrutinize the table summarizing empiric therapy among adult inpatients with non-severe CAP. Let's now look at empiric therapy among adult inpatients with severe CAP. Combination therapy with beta-lactam backbone is recommended based on data showing improved outcomes with combination therapy in this patient population. The major change in the 2019 guidelines is there is no more HCAP and there are very specific indications for when to provide MRSA and/or Pseudomonas aeruginosa coverage. See Table 8. Pause the video and scrutinize the table summarizing empiric therapy among adult inpatients with severe CAP. Pause the video and scrutinize the table summarizing other treatment considerations. Pause the video and scrutinize the table summarizing directed therapy of CAP in adult patients. Let's briefly look at newer therapies. Omadacycline. It is a novel tetracycline antibiotic which covers most gram-positives including MRSA and drug-resistant Streptococcus pneumoniae. It covers common CABP gram-negatives such as Haemophilus influenza and Moraxella catarrhalis, and also covers many Enterobacteriaceae and Acinetobacter species. It has no coverage against Proteus species, Providencia species, Morganella species, or Pseudomonas aeruginosa. It covers CABP caused by the atypical bacteria Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella pneumophila. It was approved by FDA for adult CABP at a dose of 200 mg IV stat, or 100 mg IV every 12 hours for 2 doses, then 100 mg IV every 24 hours or 300 mg orally every 24 hours. A Phase 3 randomized controlled trial showed it is non-inferior to moxifloxacin. It is also approved for ABSSSI in adults. Let's briefly look at lefamulin. It is a semisynthetic chloromutilin, which inhibits protein synthesis via 50S ribosomal peptidyl transferase interference. It covers most gram-positives activity including MRSA and drug-resistant Streptococcus pneumoniae. It has no coverage against Enterococcus faecalis. It covers common CABP gram-negatives such as Haemophilus influenza and Moraxella catarrhalis. It has no coverage against Enterobacteriaceae, Pseudomonas aeruginosa or Acinetobacter baumannii. It covers CABP atypical bacteria like Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella pneumophila. It was approved by FDA for adult CABP at a dose of 150 mg IV every 12 hours or 600 mg orally every 12 hours. The LEAP-1 and LEAP-2 Phase 3 randomized controlled trials showed it is non-inferior to moxifloxacin with or without linezolid. Let's briefly look at IV to oral transition and duration of therapy for adults. Most patients treated with CAP were historically treated for 7 to 10 days. Data from clinical trials involving telithromycin and levofloxacin 750 mg daily demonstrated success with 5 days of therapy. Data from randomized clinical trial applying 5-day minimum and CAP-associated stability criteria for antibiotic discontinuation demonstrated reduced antibiotic duration without compromise in clinical outcomes. Pause the video and scrutinize the table which summarizes criteria for IV to oral transition and discontinuation of antibiotic therapy for adults with CAP. We will briefly look at influenza vaccination. The Centers for Disease Control and Prevention (CDC) recommends all individuals age equal to or above 6 months without a contraindication receive seasonal influenza vaccine. Pause the video and scrutinize the table summarizing contraindications and precautions for receipt of seasonal influenza vaccination. Pause the video and scrutinize the table summarizing treatment of patients with confirmed or suspected influenza. Let's now shift gears and look at pediatric CAP, with an emphasis on common pathogens. Viral CAP is the most common type, especially among children younger than 5 years old. It is mainly caused by 1. Respiratory syncytial virus, 2. Human rhinovirus, 3. Adenovirus, 4. Influenza A or B viruses. Bacterial pathogens include 1. Streptococcus pneumoniae, 2. Mycoplasma pneumoniae, 3. Staphylococcus aureus, 4. Viridans streptococci. Note, the etiology varies by age, with viruses more common in younger children, that is age less than 5 years. Let's now shift gears and look at pediatric CAP, with an emphasis on outpatient empiric therapy. In cases due to typical bacteria, it usually presents with more severe symptoms. In cases due to atypical bacteria, they usually have slower or more insidious onset. Sometimes they cause less inflammation, with more diffuse or patchy radiographic findings. We should avoid doxycycline in children or patients aged below 7 years, due to the risk of tooth discoloration. Pause the video and scrutinize the table summarizing empiric antibiotic therapy for pediatric patients with CAP treated in outpatient setting. And now, let's shift gears and look at pediatric CAP, with an emphasis on inpatient empiric therapy. Recommendations are stratified by risk of resistant Streptococcus pneumoniae. Considering vaccination status, whether they have received Haemophilus influenza type B vaccine (HIV), and pneumococcal conjugate vaccine, and local epidemiology with a focus on penicillin-resistant Streptococcus pneumonia. Pause the video and scrutinize the table summarizing empiric antibiotic therapy for pediatric patients with CAP treated in inpatient setting. Pause the video and scrutinize the table summarizing directed therapy of CAP in pediatric patients. Pause the video and scrutinize the table summarizing epidemiology of nosocomial pneumonia. Pause the video and scrutinize the table summarizing common hospital-acquired pneumonia and ventilator-associated pneumonia pathogens. And now, let's look at diagnosis of nosocomial pneumonia. Its diagnosis should be based on clinical criteria alone. Biomarkers are not recommended. They include procalcitonin, that is, PCT, soluble triggering receptor expressed on myeloid cells, also known as STREM1, or C-reactive protein, also known as CRP. Lack of clinical outcomes data, sensitivity and/or specificity less than 90% threshold set by expert panel. PCT has sensitivity issues and false negatives to occur. The reasons for observed 67% with a 95% confidence interval of 53 to 79% sensitivity in HAP or VAP is unclear. It may have been measured too early. PCT rise lags by approximately 6 hours from infection onset. B. Atypical pathogens do not result in PCT increase. This should not be a major concern in HAP or VAP where these pathogens are rare. C. Corticosteroids, PCT is thought to be unaffected by immunosuppressive medications and conditions. D. Variable PCT cutoffs used across studies 0.5 to 3.9 nanograms per milliliter. It is difficult to optimize both sensitivity and specificity. E. It is an imperfect comparator. It is difficult to distinguish between true pneumonia and colonization or tracheobronchitis. C. Strem 1 had specificity issues due to false positives. D. CRP has both sensitivity and specificity issues due to false negative and false positives. 2. Modified Clinical Pulmonary Infection Score, also known as CPIS, is not recommended. There is a lack of clinical outcomes data. Sensitivity and specificity less than 90% threshold was set by expert panel. Blood cultures are recommended for all patients with suspected HAP or VAP. They are especially important in VAP where approximately 15% of patients have concomitant bacteremia. Non-invasive respiratory cultures are recommended for all patients with suspected HAP or VAP. In HAP, spontaneous expectoration, sputum induction, nasotracheal suctioning should be done. In VAP, spontaneous expectoration, sputum induction, nasotracheal suctioning, endotracheal aspiration should be done. Outcomes studies showed there was no difference in clinical outcomes in non-invasive versus invasive cultures in patients with VAP. Let's now look at considerations in selecting empiric therapy for HAP. Determine whether mortality risk is high. If there is a high risk, cover MRSA and double cover Pseudomonas aeruginosa because patients at higher mortality risk have a narrow margin of error when determining empiric therapy. It needs to be right the first time. Establish 1. Is there need for ventilator support due to pneumonia? 2. Is there a presence of septic shock? Identify the need for MRSA coverage. 1. Has the patient received IV antibiotics in prior 90 days? 2. Are the patients undergoing treatment in units where MRSA prevalence is greater than 20% or unknown? A 20% MRSA prevalence cutoff for MRSA coverage was selected by expert committee to balance need for early effective antibiotic therapy and limit excessive unnecessary use of MRSA coverage. Determine the need for double coverage of Pseudomonas aeruginosa by asking yourself the following questions. 1. Have IV antibiotics been administered to the patient in prior 90 days? 2. Is a structural lung disease, bronchiectasis or cystic fibrosis present? We will now look at considerations when selecting specific antibiotics for empiric HAP therapy. Vancomycin and linezolid are considered equal based on data from randomized trials. A. Vancomycin is usually preferred in clinical practice due to lower cost and in an effort to preserve linezolid's susceptibility for culture-confirmed infections. No single anti-pseudomonal antibiotic is considered superior to another based on currently available outcomes data. With one exception, no aminoglycoside monotherapy for Pseudomonas aeruginosa. A. There is a lack of clinical outcomes data to support aminoglycoside monotherapy for serious Pseudomonas aeruginosa infections. B. Some data even indicate inferiority relative to other agents. Pause the video and scrutinize the table summarizing empiric antibiotic therapy for adult patients with HAP at low risk for mortality and MDR pathogen or pathogens. Pause the video and scrutinize the table summarizing empiric antibiotic therapy for adult patients with HAP at high risk for mortality and/or MDR pathogen or pathogens. Let's now look at the considerations in selecting empiric therapy for VAP. We should identify risk factors for MDR VAP, which include 1. The use of IV antibiotics in the past 90 days, 2. The presence of septic shock. 3. Acute respiratory distress syndrome ARDS, preceding VAP. 4. Greater than or up to 5 days of hospitalization prior to VAP, and 5. Acute renal replacement therapy prior to VAP. We need to identify the need for MRSA coverage. This can be when 1. MDR VAP risk factor or factors exist, or 2. During treatment in units where MRSA prevalence is greater than 10 to 20% or unknown. A 10% threshold, 10 to 20% for MRSA, was chosen by an expert panel to ensure that greater than or up to 95% of patients with VAP would receive initial active therapy. We need to identify the need for double Pseudomonas aeruginosa coverage by determining MDR risk factors, that is 1. MDR VAP risk factor or factors. 2. During treatment in units where gram-negative bacilli resistance is greater than 10% or unknown. We need to identify consideration when selecting specific antibiotics for empiric VAP therapy. Same as above for empiric HAP therapy. Pause the video and scrutinize the table summarizing empiric antibiotic therapy for adult patients with VAP with no MDR VAP risk factors and local gram-negative bacilli resistance less than 10%. Pause the video and scrutinize the table summarizing empiric antibiotic therapy for adult patients with VAP with no MDR VAP risk factors and local gram-negative bacilli resistance greater than 10%. Pause the video and scrutinize the table summarizing empiric therapy, MDR VAP risk factors. Pause the video and scrutinize the table summarizing pathogen-specific therapy for treatment of HAP or VAP caused by MRSA, Pseudomonas aeruginosa, or Acinetobacter species. We will briefly consider the ZEPHYR study comparing vancomycin versus linezolid in adult patients with MRSA pneumonia. It was a Phase 4, multi-center, randomized, double-blind, controlled trial in adult patients with MRSA pneumonia. They compared linezolid 600 mg IV every 12 hours versus vancomycin 15 mg per kilogram every 12 hours, adjusted to trough 15 to 20 mg per liter, for 7 to 14 days, prolonged to 21 days if there was concomitant bloodstream infection. And now pause the video and scrutinize the table and figure summarizing the outcomes of this trial. The proportion of patients with clinical cure was greater in the linezolid group relative to the vancomycin group at both end of treatment (EOT) and end of study (EOS). There was no difference in 60-day mortality observed between treatment groups. Let's now look at study limitations. 1. The groups were imbalanced at baseline. There were more mechanical ventilation and bacteremia patients in the vancomycin arm. 2. There was suboptimal vancomycin dosing. For the majority, day 3 trough concentrations were less than 12.4 mg per deciliter. 3. A large proportion of the linezolid arm were excluded for no response recorded. 4. The sponsor was able to override individual patient outcome decision. Treatment guidelines consider the two drugs comparable in efficacy despite higher clinical and microbiologic success rates with linezolid in this and other clinical trials due to study limitations and equivalent mortality. Pause the video and scrutinize the table summarizing pathogen-specific therapy for treatment of HAP or VAP caused by ESBL-producing gram-negative bacilli or carbapenem-resistant organisms. Let's now ponder over the question, is there a potential role for newer antibiotic therapies? Examples of these therapies are 1. Ceftolozane tazobactam, 2. Ceftazidime avibactam, and 3. Meropenem vabibactam. Let's now look at the Marino trial, in which there was a comparison of piperacillin tazobactam versus meropenem for ceftriaxone-resistant Escherichia coli and Klebsiella pneumoniae bloodstream infection. It was an international, multi-center, randomized, open-label, non-inferiority clinical trial in adult patients with ceftriaxone or cefotaxime-resistant, piperacillin-tazobactam and meropenem-susceptible Escherichia coli or Klebsiella pneumoniae bloodstream infection. The regimens used were piperacillin-tazobactam 4.5 grams infused over 30 minutes every 6 hours versus meropenem 1 gram infused over 30 minutes for 4 to 14 days. Pause the video and scrutinize the figure summarizing the outcomes of the Merino study. Let's now look at the study limitations. 1. Samples were predominantly, that is greater than 50%, urinary source. 2. There was minority pneumonia source approximately 3%. 3. 2/3 of the patients received prior appropriate antibiotic therapy. 4. There could have been suboptimal dosing. A. There was a lack of extended infusion which could reduce efficacy, particularly in piperacillin-tazobactam patients, and b. A sub-maximal meropenem dosing was used, typically 2 grams every 8 hours is recommended for severe infections. Let's now look at the conclusion and relevance to ESBL pneumonia. The randomized controlled trial data suggesting piperacillin-tazobactam may not be equivalent to meropenem for serious ESBL infections. In the absence of randomized trial in ESBL pneumonia, this trial is the strongest evidence to date when choosing between piperacillin-tazobactam and meropenem for serious infections such as pneumonia. Let's now look at newer therapies. We will begin with ceftolozane-tazobactam. It is a novel cephalosporin, with activity against many MDR gram-negative bacilli, e.g. A, most ESBL and AMP-C producers, and b, many carbapenem-resistant, Pseudomonas aeruginosa strains. It has no activity against carbapenemase producers. It has limited gram-positive activity, including no staphylococcal activity. It is FDA approved for hospital-acquired bacterial pneumonia, HABP, or ventilator-associated bacterial pneumonia, VABP, in adults. It proved non-inferior to meropenem for HABP or VABP in the ASPE-CTNP trial. The majority of pathogens in this trial included carbapenem-susceptible pathogens. Observational data suggests ceftolozane-tazobactam is associated with improved clinical cure and reduced acute kidney injury compared with colistin or aminoglycoside-based combination therapy regimens for MDR or XDR Pseudomonas aeruginosa. Approximately 50% of patients in this trial had VAP and approximately 20% had HAP. Let's now look at ceftazidime-avibactam. It is a novel beta-lactamase inhibitor plus a cephalosporin combination, with activity against many MDR gram-negative bacilli. It covers most ESBL and AMP-C producers and most CRE, including KPC and OXA48. It has limited gram-positive activity, including no staphylococcal activity. It is FDA approved for hospital-acquired bacterial pneumonia, HABP, or ventilator-associated bacterial pneumonia, VABP, in adults. In the REPROVE trial, which was an RCT of nosocomial pneumonia, it was non-inferior to meropenem. There were approximately 5% carbapenem-resistant organisms, less than 1% CRE in this trial. Ceftazidime-avibactam is associated with improved survival over colistin-containing regimens for CRE bloodstream infections in multiple retrospective, observational studies. There were less than 25% of patients with pneumonia source in the trial. Let's now look at meropenem-avibactam. It is a novel beta-lactamase inhibitor plus carbapenem combination with activity against many MDR gram-negative bacilli. Like most ESBL and AMP-C producers and KPC producing CRE, but it doesn't inhibit OXA48. It has activity against most non-MDR gram-positive pathogens, but no MRSA coverage. It is FDA approved for CUTI in adults. In the TANGOI trial, meropenem vabibactam was non-inferior to piperacillin tazobactam for CUTI. There were few carbapenem-resistant organisms in this trial. Let's now look at the Tango 2 trial. It compared meropenem vabibactam versus best available therapy, BAT, for CRE infections. It was terminated early by Data Safety Monitoring Board as enrollment into BAT was not in the best interest of patients. Clinical cure was significantly more common in the meropenem vabibactam group. Only approximately 10% of patients in CRE population had pneumonia, that is 4 patients in the meropenem vabibactam group versus 1 patient in the BAT arm, which limits direct applicability of these findings to patients with HAP or VAP. The study included patients commonly afflicted with CRE, with multiple comorbidities, e.g., renal impairment or end-stage renal disease, immune system compromise from leukemia, lymphoma, or solid organ or stem cell transplantation. It strengthens generalizability by including patients similar to those drug will be used in and resulting in 72.7% KPC-producing strains, which are the most clinically important CRE in the US and many areas of the world. Let's now look at the application of PK/PD and dose optimization. Guidelines recommend antibiotic dosing should be determined using PK/PD principles data rather than prescribing information. This is because the possible benefits are more important than the cost or burden, and there is decreased mortality, decreased ICU stay, and increased clinical cure rate when looking at combined strategy of PK/PD-informed dosing. Pause the video and scrutinize the table summarizing guideline recommended applications of PK/PD for dose optimization. We will now look at vancomycin therapeutic drug monitoring. Guidelines suggest maintaining a UC to MIC ratio equal to or more than 400 for complicated Staphylococcus aureus infections including pneumonia. They recommend a UC equal to or more than 400 mg/hour per liter for isolates with MIC of 1 mg per liter, based off Staphylococcus aureus isolates. We should target trough concentration of 15 to 20 mg per liter, surrogate for a UC equal to or more than 400 mg/hour per liter, or a UC 400 to 600 mg/h per liter. The loading dose is 25 to 30 mg per kilogram, based on actual body weight in seriously ill patients. It is only recommended for seriously or critically ill patients, who are common among HAP or VAP cases. The maintenance doses are 15 to 20 mg per kilogram, based on actual body weight, every 8 to 12 hours. It depends on renal function. We should draw trough concentration, or compute a UC, at steady state, that is at 5 times the half-life, T1/2, which is usually before 4th dose. It depends on renal function and dosing scheme and may not be before the 4th dose. We will now look at individualized vancomycin dosing. It is a population-based pharmacokinetic parameter estimation, that is before serum concentration is drawn. The volume of distribution, VD, is 0.7 liters per kilogram. It could be different depending on patient. The elimination rate constant Ke is calculated using the formula Ke equals 0.00083 multiplied by the CRCl. All plus 0.0044. The half-life, T1/2, is calculated using the formula, T1/2 equals 0.693 divided by Ke. Let's now look at the dosing regimen adjustment using single vancomycin trough concentration, dose change, concentration at steady state abbreviated as Cs, S, nu divided by the new dose, dose nu, is equal to the old concentration, Cs, S, old divided by the old dose, dose old, or AUC nu divided by dose new equals to AUC old divided by dose old. Asterisk refers to keeping interval constant, that is trough just slightly outside of goal range. The dosing interval change, tau new asterisk Cs, S, new equals to tau old asterisk Cs, S, old, asterisk trough is significantly outside of range, keeping dose constant, change interval, as you change interval, however, estimated trough concentration may be a little off. Changing both dose and interval, Cs, S, nu divided by 24 hours dose new equals Cs, S, old divided by 24 hours dose old, asterisk use 24 hours cumulative dose to find out new 24-hour cumulative dose would be based on targeted trough and then divide into desired dosing interval. We are able to use proportions because vancomycin undergoes first-order elimination pK. Steady-state SS trough concentration is directly proportional to dose given. If dosing interval change, alone or along with dose shortening interval, i.e., every 12 hours to every 8 hours, leads to the actual trough becoming more than the estimated trough. Extending interval, i.e., every 12 hours to every 24 hours, leads to an actual trough less than the estimated trough. Pause the video and scrutinize the table recommendations regarding the use of inhaled antibiotics for treatment of VAP. Pause the video and scrutinize the table summarizing recommendations regarding the use of polymyxin antibiotics for treatment of HAP or VAP. Pause the video and scrutinize the table summarizing duration of antibiotic therapy for HAP and VAP. We will now briefly look at antibiotic de-escalation in patients with HAP or VAP. De-escalation of antibiotics is recommended when possible, that is, we should switch from empiric broad-spectrum therapy to therapy with narrower spectrum of activity. Clinical evidence comparing de-escalation to fixed, broad-spectrum therapy showed 1. No significant difference in mortality or ICU length of stay. 2. Conflicting evidence regarding impact on pneumonia recurrence. 3. De-escalation may increase antimicrobial days, superinfection rates, and MRSA emergence. The recommendation is based on expert clinical experience and clinical rationale. De-escalation should reduce cost, burden, and antimicrobial resistance, and it is doubtful that de-escalation could increase antibiotic days and superinfection. We will now briefly look at procalcitonin, PCT concentrations to guide antibiotic discontinuation. We should use PCT concentrations plus clinical criteria to guide antibiotic discontinuation. Clinical stability. There is no specific criteria given in guidelines or individual studies. PCT concentration less than 0.25 nanograms per milliliter or a decrease of greater than 80% from baseline is the most commonly used threshold to encourage antibiotic discontinuation. PCT less than 0.1 nanograms per milliliter or greater than 90% decrease is sometimes used to strongly encourage antibiotic discontinuation. Evidence is predominantly from patients with VAP and has been extrapolated to patients with HAP. Clinical evidence supporting use of PCT concentrations includes 1. Shorter durations of antibiotic therapy, and 2. No significant difference in mortality, pneumonia recurrence, mechanical ventilation duration, ICU or hospital length of stay, and resistance development. And now, let's look at a summary of lower respiratory tract infection pharmacotherapy. Empiric antimicrobial therapy selection for patients with lower respiratory tract infections requires consideration of the common pathogens and a multitude of site and patient-specific factors, like 1. Community-acquired versus nosocomial-acquired, 2. Local antimicrobial susceptibility patterns, 3. Risk factors for antimicrobial-resistant pathogens, and 4. Severity of illness. Infectious diseases pharmacists play an important role in evidence-based treatment of lower respiratory tract infection through interpretation, diagnostic tests, antimicrobial regimen selection including agent, dose, and duration, and patient monitoring and therapy modification. Thank you.